In class, I am going to continue the next revision of the topic, which is preparative value, preparative care. So, as we know, the patient assessment is extremely important, and you should know that the purpose of careful pre-operative planning is to minimize the unwanted effects of surgery. So, let us talk about that. Now, first of all, you must remember that at the start of each consultation, the surgeon should introduce himself to the patient, explaining who or she is. The patient details should be confirmed. In history, do not assume that the history has already been adequately covered previously. Important points may have been overlooked in a busy outpatient clinic. In addition, there may have been a substantial delay between the clinical appointment and the admission for surgery, during which the time, symptoms, and sign may have changed considerably. There are a number of useful principles to adhere to when taking a history. That is, first, listen. What does the patient see as the problem? Patients are allowed to describe their symptoms in their own words. Clarify. What does the patient expect? Clarify details in the history and explore the patient's hopes and fears. Narrow the differential diagnosis, focus question. Formulate a as the story unfolds, with the most likely first. The order may change as the history progresses. Finesse. Comorbidities exist. Some aspects of the history are not directly relevant to the diagnosis in the hand, uh, but will also be vital if anesthesia and surgery are eventually necessary. Other conditions could alter the surgical plan or adversely affect the outcome unless they are identified and optimized. So, what other terms are necessary? That is the presenting complaint. First few lines of the history should include the age and sex of the patient. Hardly one sentence summarizes the immediate problem. Then is the history of the presenting complaint. Let's talk about that. The this should history of presenting complaint describes the time course and severity of the patient's symptoms. Some assessment of the extent to which the problem is interfering with the patient's life should be made. What has the patient already tried to relieve the symptoms? And what does the patient hope to achieve from any possible surgery? A useful mnemonic to help remember which of the basic features of the presenting complaint to explore is the SOAP. It means S for symptoms, O onset, R relieving factors, E exacerbating factors, P pain during the nature and radiation, O other therapies, P planned surgery, E expectations. After that is past medical history. There will frequently be many negative responses in this section, but any positive findings need to be recorded in some detail, including dates, causes, treatment, and subsequent control of the symptoms. Uh, Moving on is the drug history. Many patients also take alternative therapies such as herbal remedies or Chinese traditional medicine, common in China. Now it is becoming popular in Pakistan also. It is important to list these as some therapies can interfere with the action of drugs such as warfarin. Inquiries should also be made about illegal drug use and any rehabilitation program being followed. Ask about any allergic reactions, including their severity. Social history should include smoking, alcohol history, as well as patient occupation and social circumstances. Social support is particularly important for the frail elderly. Homeless patients and IV drug abusers present different challenges, as do those who are sole caterers for disabled relatives. Identify problems early to formulate a sensible post-security plan and prevent delaying discharge. Uh, Key topics in the past history include the cardiovascular, respiratory, GIT, genitourinary, neural, endocrinal, locomotor, or other includes HIV, hepatitis, or history of previous surgeries. This is the ASA classification of physical status. One is normal patient, A patient with two with mild symptoms, three severe systematic, four severe systematic disease that is constant threat to life, five or more moribund patient who is not expected to survive, six a declared brain dead patient. Moving onwards to the examination, keep patient warm and comfortable while they are being examined, and always treat them with respect. Only expose parts of the body as they are required. Ideally, chaperone should always be present, but this should certainly be the case for intimate examination such as the vaginal or rectal examination. A full explanation of what is being done, why should be provided throughout. It should be told to the patient. Painful areas should be approached with special caution, and the patient face washed throughout to check for signs of discomfort. First possible differential diagnosis should be actively excluded, and new complications that might make surgery more difficult highlighted. Example, an inguinal hernia developing signs of bowel obstruction. Second, a general medical examination should be performed to identify the presence and severity of any comorbidities. If an operation has known complications, like shutting nerve damage in a patient receiving a total hip replacement, it is important to record the situation pre-operatively. Now, the patient's nutritional status deserves special mention. This is an important determinant of surgical outcome. Patients with pre-existing nutritional impairments who are likely to be denied nutrition for a significant length of time because of the nature of the surgery, or who have been septic or significantly injured, are all at special risk. The body mass index should be estimated for all patients if possible. Body weight is in kilogram divided by height in meters squared gives the BMI. A BMI of less than 18.5 indicates nutritional impairment, and BMI of less than 15 is associated with significant hospital mortality. Ask about recent weight loss and look for muscle wasting, loss of subcutaneous fat, edema, and alopecia if present. Examination key points are general includes anemia, jaundice cyanosis. Cardiovascular includes the pulse, blood pressure, heart sounds, roots. Respiratory includes the rate and effort, chest expansion. Uh, Gastrointestinal includes the abdominal masses such as ascites, etc. Neurological includes conscious level, any pre-existing cognitive impairment. Now, when the examination is complete, patient should be covered and made comfortable before discussing the post-management plan. Allow the patient to ask questions. Question. Uh, Another thing after examination is about investigations. Now, these should be ordered only when clinically indicated. Most hospitals have protocols to guide pre-operative investigation requests. These are helpful but should not be followed blindly, as supplementary investigations are often required to aid surgical or anesthetic planning. Request forms should be filled in clearly, including explanation for why the request has been made. Record test results clearly in the notes, as well as the action taken to resolve any problem identified. Investigations that are commonly needed are, for example, for blood count. This will be necessary in young women with menorrhea or in any patient whose surgery may involve significant blood loss. Others are urea and electrolytes, liver function tests, for example, indication in patient with jaundice, uh, ABG, alternative blood gases, occasionally required for detailed assessment of some respiratory conditions. ECG, usually required anyone over the age of 65, in all patients in whom significant blood loss is possible. Chest radiography, not usually required unless the patient has a significant cardiac history or respiratory problems. Temperature, patient with pyrexia should not be operated on until the cause has been identified. Urine analysis, usually by dipstick testing for urine, is usually carried out preoperatively and can detect UTIs. Other may include HIV, serology testing should be such testing such as this should be undertaken in any patient with a past history of high risk exposure to infection, bodily fluids, hepatitis, or other things. Now, moving onwards, I will talk about certain special areas. For example, screening evaluation for the pulmonary should include questions regarding history of tobacco use, dyspnea, shortness of breath, cough, wheezing. The patient should also be questioned regarding the presence or recent history of upper tract infections. Auscultation can detect decreased breathing sounds and wheezing. Talking about cardiovascular diseases, this can include hypertension. The number of operations cancelled because of uncontrolled hypertension has been substantially reduced by preoperative assessment clinics. Patients with systolic blood pressure of 160 or above and diastolic pressure of 95 or above should have elective surgery deferred until their blood pressure is under control. Uh, Myocardial infarction is a strong contraindication to elective anesthesia. There is a significant mortality rate from anesthesia within 3 months of infarction, and elective procedures should ideally be delayed until at least 6 months elapse. Dysrhythmias, fast atrial fibrillation must be controlled before surgery. The intervention necessary depends on the physiological state of the patient and the urgency of the surgery required. Regular measurements of the serum potassium is essential, particularly if digitoxin is being used. Other complications like cardiac failure, this needs careful workup preoperatively and will require special medical input. Oxygenation and fluid balance are of critical importance in these patients. When talking about Indian blood transfusion, preoperative anemia may result from bleeding or as a result of a chronic disease. Preoperative transfusion should be considered if the preoperative hemoglobin concentration is below 8 gram per deciliter, or the patient is symptomatic or actively losing blood. So these are some reasons for areas of that require cardiovascular uh, issues. Also, exercise tolerance is one of the most important determinants of perioperative risk and the needs for further testing and invasive monitoring. Inability to walk 4 blocks, with one block being 100 to 200 meters, or climb 2 flights of stairs is defined as poor exercise tolerance. So, moving onwards, we are going to talk a bit about the neurological issues or what may be pertained regarding this particular area. Uh, Peripheral neuropathies or myopathies may require prolonged ventilation postoperatively, and this should be anticipated. Anticonvulsants need to be continued perioperatively, may need to be changed to IV forms if starvation is prolonged. Apart from that, Screening for the neurological system is apparently in apparently healthy patient can mostly be accomplished through simple observation. Patient ability to answer health-related questions practically ensures a normal mental status. This can exclude the presence of increased intracranial pressure, cerebrovascular diseases, seizures, or any pre-existing neuromuscular diseases. Uh, Finally, endocrine system. Each patient should be screened for endocrine disease that can affect the perioperative course. That includes diabetes or thyroid diseases. Some of the recommended laboratory testing I've decided to include ECG, age 50 or older, diabetes mellitus, hypertension, current or past significant cardiac disease, current or past respiratory disease, diabetes mellitus, renal, thyroid, or other metabolic disease. This is procedure level 5, or any procedure level 5. Chest X-rays, asthma or COPD, cardiothoracic procedures. Serum chemistries include renal diseases, adrenal thyroid disorders, diuretic therapy, chemotherapy, urinalysis, diabetes mellitus, renal disease, genitourinary procedures, recent genitourinary infections, metabolic disorders, and complete blood count in hematological disorders. So that is for important areas. Uh, let's talk a bit about the general preoperative preparation. It includes psychological support, removal of cosmetics, menstruation is not a contraindication, and fasting. Other things include securing the IV routes, emptying intestines, nasogastric catheter, unique catheters if necessary, toileting, that is include bathing and shaving, thrombosis prophylaxis, and antibiotic prophylaxis. Uh, that is briefly the importance or the necessary requirement for you to understand the lecture about the pre-operative examinations. And at the level of physiotherapy, this is enough for you to understand. Now, again, if you have any questions, you can ask me later.